Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through heart failure pharmacology. Let's begin, as we always do, with the basic pathophysiology review. Heart failure occurs when the cardiac output is not enough to meet the metabolic demands of the heart. Again, the cardiac output is measured in blood, but obviously the metabolic demands, meaning is it delivering enough oxygen-rich blood to every cell in the body. Cardiac output is a mathematical formula. It's calculated by heart rate, the amount of beats per minute, times stroke volume, the amount that the heart squeezes out with every contraction of the heart. The heart rate times the stroke volume gives you your cardiac output. Stroke volume depends on preload, which is the volume getting returned to the heart, afterload, which is the resistance the heart is pumping against, and myocardial contractility, which is the actual squeezing or contracting of the heart. We're going to talk about each of these as we go through heart failure pharmacology. Heart failure is divided into two subclasses. There's HFrEF and HFpEF. HFrEF is heart failure with reduced ejection fraction, and HFpEF is heart failure with preserved ejection fraction. And we'll talk more about that in just a minute. Pharmacologically, we generally treat with three different drug classes, and most patients that have heart failure, especially significant heart failure, will be on all three of these drug classes. Not that we start all three at the same time, but this is what we're going to work towards. A diuretic, a RAS inhibitor, such as an ACE or an ARB, and a beta blocker. Generally, they're going to be on all three of these. It's critical to educate patients about their disease and about the management, because heart failure is really complicated. As of a few years ago, I don't know current statistics, but it had roughly a 50% 5-year mortality, meaning if someone was diagnosed with heart failure, odds are 50-50 that in 5 years they are dead. Because of this, it's critically important for us to be really on top of their treatment and to use or help them help themselves to also manage their disease. We have to make sure they're compliant with their medication, that they follow a low sodium diet, that they're following any fluid restrictions that they have, that they're monitoring their disease, and that they're getting enough exercise. Let's talk a little bit about the signs and symptoms, because you're definitely going to see this on a pharmacology exam. Left-sided heart failure is going to be where the left side of the heart is backed up, which means it's going to back up into the lungs. You have to remember that. The symptoms over there are going to be fatigue, exertional dyspnea, orthopnea, and a few other things. Versus right-sided heart failure. Right-sided heart failure is where the right side of the heart backs up, so that's going to back up into the central circulation. So that's going to have peripheral edema, JVD, and things like that. And obviously, in some cases, patients will have both. There's a lab called BNP, or the newer version is the NT-proBNP, but these are a common lab to check for heart failure. If it's elevated, that is a sign of heart failure. Next, we have ejection fraction. Ejection fraction is how we diagnose a patient whether or not they have heart failure. A normal ejection fraction, or EF, is roughly 55 to 70%. There is some textbooks out there that have slightly different numbers, 50 to 70, 50 to 75. We're going to go with 55 to 70% is going to be a normal EF. If a patient has the signs and symptoms of heart failure, but their EF is still above 55, that means they have HFpEF. If their EF is below 55, they have heart failure with reduced EF. Obviously, we want that number to be as high as possible. 55 to 70 is the range, so we want them to be in there, but it's possible for patients to work their way even up above that if they're really athletic and their cardiovascular system is in really good shape. Finally, any patient who's in heart failure must be monitored for fluid status. Remember, the heart is the pump that's responsible for pumping all the fluid, so that's a really big deal to monitor their fluid. Now let's start to go through medications. As we said a few minutes ago, every patient who has symptomatic heart failure is going to end up on all three of these, an ACE or an ARB, plus a diuretic, plus a beta blocker. Let's start with the ACEs and ARBs. All of these drugs have been covered in other lectures, all of them. So I'm going to go through them relatively quickly here, because I assume by the time you got to heart failure, most of your schools will have already covered either hypertension or diuretics or some of these other drug classes. So you should have seen all of this already. This is just a refresher. Starting with ACEs, ACEs work by blocking the renin-angiotensin-aldosterone system. The RAS, or renin-angiotensin-aldosterone system, works to bring up our blood pressure. So ACEs bring down our blood pressure because it stops that system. How does that help for heart failure? Well, we just said a few minutes ago that heart failure and cardiac output is dependent on three factors: preload, afterload, and contractility. ACEs and ARBs work as follows. They reduce afterload. Afterload is how tight, how constricted is the aorta, because the tighter the aorta, the harder the work of the heart. The heart's job is to push blood into the aorta. If the aorta is nice and big, it's easy to push blood into it. If the aorta is really tight, if it's really constricted, it is really hard to push blood into it. So when a patient has heart failure, we want to reduce their afterload. A high afterload means the vessels are constricted. We want to reduce the afterload, which means the vessels are dilated. And vessel, we're talking specifically, in this case, the aorta. So again, heart failure is treated by affecting the afterload, the preload, or the contractility. ACEs and ARBs both work by reducing afterload. Another way to put that, and a way I've seen it in a bunch of test banks, is they put it as reducing the work or the exertion that the heart has to do to overcome. The heart has to overcome the afterload. It's what it's fighting against. By reducing the afterload, we reduce how contracted or constricted the aorta is. We reduce how hard the heart has to work. If the heart doesn't have to work as hard, that's a win for a patient with heart failure. That's how ACEs and ARBs work. Again, I'm not going through the whole drug class. It's listed here on the screen, and it's been covered in other lectures. ACEs and ARBs, that's how they work. Let's move on to beta blockers. Beta blockers work differently. Again, just to recap, we've talked about beta blockers in so many different lectures, but real quick, they block beta. Beta 1 makes the heart beat faster, harder, stronger. In this case, it's going to make the heart beat a little less hard, a little less fast, a little less strong. Now, if you're thinking that's counterintuitive, the patient's in heart failure, that means that we want the heart beating harder and faster and stronger, not the opposite. How in the heck does a beta blocker help? That's a really good question with a really good answer. So the answer is as follows. When a patient's heart is beating really fast, 1, 2, 3, 4, 5, it's beating really fast, the heart barely got a chance to fill up between every squeeze. So because the heart barely got a chance to fill up with every squeeze, the body is putting the effort into squeezing the heart over and over and over again, but it's not really getting, so to speak, its bang for its buck. It's not getting good value out of each squeeze. It's putting the work into squeeze, but the heart never really filled back up because it's one beat after another, after another, after another. If the heart didn't fully fill back up, then that squeeze was effort put in, but you didn't get the full money's worth out of that effort. So by slowing down the heart, even though I might get less beats per minute, that serves two purposes. A, I'm getting less beats per minute. So it's less work on the heart, which is a good thing in a heart failure patient. Plus, each contraction, the heart actually fills up more. So the contraction is more effective. So it's putting in less work and getting more results, which is highly efficient. And that's what we're going for with beta blockers. Hopefully you understood that. If not, go ahead, pause, repeat it again. That's how we help with beta blockers. So again, so far we talked about ACEs and ARBs. They're going to reduce the afterload. Beta blockers are going to work to reduce the actual work of the heart, plus make the heart more efficient in terms of their contractions. And then finally, we have the diuretic. So for heart failure, most commonly, we would use a loop diuretic, maybe a low-dose furosemide to start off with. And this works by diuresing. So again, I'm not going to go to the details of the drug. We discussed it earlier, and it's on your screen. But I just want you to understand, loop diuretics work in a heart failure patient as follows. In a heart failure patient, the heart is unable to keep up with the work that it's supposed to do. Your heart is supposed to pump your entire blood volume every 60 seconds. It's pretty amazing. So in every 60 seconds, let's say an average healthy adult male has 6 liters of blood, give or take. So the heart's job is to pump 6 liters of blood. However, in a patient that has heart failure, the heart is failing. It is unable to keep up with the job that it's supposed to do. It's supposed to pump those 6 liters. It's unable to do that. By giving a patient a diuretic, we take a little bit off of that workload by simply reducing the volume. We make it that the patient has a little bit less volume. And honestly, more commonly in heart failure patients, pathophysiologically, we're just trying to make sure they don't have excess volume, not so much reduce the actual volume, just make sure they don't have anything more than is absolutely needed. So we want to make sure they have a tight number on that blood volume so that the heart doesn't have to do any extra work. That's the role of diuretics. The next diuretic we have, in addition to the loop diuretics, are the potassium-sparing diuretics. I mentioned in one of the other lectures, I believe it was nephrology, that potassium-sparing diuretics, specifically spironolactone, this is what it is most used for. Spironolactone is most commonly used for heart failure patients. And again, it works as a diuretic. Just like we mentioned, that's how it helps heart failure patients. Next drug we have are cardiac glycosides. So the cardiac glycosides, the drug here is the digoxin, and we just discussed this in the dysrhythmia video, if you've seen that recently. And cardiac glycosides, the digoxin, it's only used for two things, dysrhythmias and heart failure. But really, we use it more so for heart failure than we do for dysrhythmias. And even for heart failure, we don't use it a ton. Digoxin has really fallen out of favor as we have newer drugs for both heart failure and for dysrhythmias. You'll notice the list I said in the very beginning of this lecture of what drug every patient who has heart failure is put on. This was not on the list. Everyone's going to get that beta blocker. Everyone's going to get the diuretic and the ACE or the ARB. This is not really there, but this is certainly a heart failure drug. This is certainly going to be on your pharmacology exam, and it's fair game for the NCLEX, so let's discuss it. So the digoxin works by increasing the effects of calcium, resulting in increased contractility. This is going to improve the contraction of the heart. So remember we said at the very beginning, cardiac output is what we're gauging when we're talking about heart failure, that and ejection fraction. But for right now, cardiac output, and we said cardiac output was heart rate and stroke volume. Stroke volume is how well the heart squeezes, how good of a job it does in contracting. Cardiac glycosides like digoxin improve the contractility. It makes that those squeezes are better, more effective squeezes. That is the job of cardiac glycosides. That's how it improves a patient with heart failure. Now we move on, not to the chronic drugs. We're done with those, or not done with those, but we're moving on to the next one. This is an acute medication. We have the PDI inhibitors like Amrinone and Milrinone. These medications are used for patients that have heart failure with reduced EF. This is for patients that other drugs have not been working to manage their heart failure. So this is where patients have either exacerbations of heart failure or really difficult to manage heart failure, end-stage heart failure, acute heart failure, etc. So Amrinone and Milrinone, we haven't discussed these anywhere else, and now let's actually get into these drugs. The mechanism of action is that they inhibit phosphodiesterase, which results in increased contractility. It makes the heart beat harder and better, just like digoxin does. What do we use it for? We use it for heart failure with reduced EF. This is a really potent medication. This is not a first-line drug. This is what we do when patients are having when we're having a difficult time managing their condition. The side effects or adverse effects of this drug are dysrhythmias and hypotension. So really keep an eye on their blood pressure and make sure they're on ECG rhythm, which anytime anyone's in acute heart failure, of course, they're going to be on a monitor. Amrinone is used less frequently due to the issue of thrombocytopenia versus Milrinone. So that's Amrinone and Milrinone. Those are two drugs for complications relating to, or not complications, but exacerbations relating to heart failure. Next, we have Entresto. Entresto is the brand name of a combo drug that's sacubitril and valsartan. This came out roughly 10 years ago. It's still under patent. And this drug has become extremely popular. It's also expensive, so patients generally need insurance for this. But this drug has become extremely popular for the treatment of heart failure. What is it? Well, it's valsartan. That's an ARB. We already talked about it. Please, on your test, recognize that valsartan's an ARB, because if a patient's on Entresto and the doctor wants to prescribe them losartan, absolutely not. That's two drugs in the same class. But sacubitril and valsartan's an ARB. We discussed that. What is sacubitril? Sacubitril is actually its mechanism of action is that it dilates the arteries of the cardiac arteries and the arteries distal to the heart. So what does that do? That reduces afterload. If you remember from a few minutes ago, we said that we want to have the aorta nice and open so that the left ventricle has an easy time pushing blood into there, versus if it's really tight and it has to really squeeze that blood into there, that increases the workload of the heart. In heart failure, we want to reduce the workload of the heart by reducing the afterload. Sacubitril works by causing vasodilation, which reduces the workload of the heart. It reduces that afterload. What do we use it for? We use it for heart failure. This is also called an ARNI, an angiotensin receptor nitrilicin inhibitor. This drug is an ARB, so it's not safe in pregnancy. But this has become a really popular medication for the treatment of heart failure. Keep in mind, this is a brand name drug, Entresto. I wouldn't expect this to be on the NCLEX. Next, we have isosorbide dinitrate with hydralazine. These are two separate drugs that are each available separately. Unlike the last one, that to the best of my knowledge, sacubitril does not exist by itself. But isosorbide dinitrate with hydralazine are each drugs that operate independently. But in heart failure, we often use them together. If they're actually in the same pill together, the drug name is Bidil, but we can actually give them each of them independently. And what is the drug? Isosorbide dinitrate dilates the veins. Hydralazine dilates the arteries. What do we use this for? Again, this is another one for HFrEF. And again, this is not a first-line drug. This is if the other medications are not working or if they're having exacerbations. The side effects of this is a big one for hypotension, because this is so potent at dilating all of your cardiovascular system, which can really bottom out your blood pressure. Because of that, it can also cause tachycardia. And because it's a vasodilator, it absolutely is known to cause a headache. Avoid taking this with the PDE5 inhibitors. And this medication is often dosed multiple times per day, which is always a negative effect because it reduces compliance the more times we have to take a drug. Very interesting for our last drug class is going to be the SGLT2 inhibitors. The sodium glucose cotransport 2 inhibitors, or SGLT2 inhibitors. These drugs you're probably familiar with as diabetes drugs, Farxiga, Jardiance, and a few others. These drugs work, and we discussed this in our diabetes lecture, by getting the body to pee out more urine. But it's also been proven that these drugs reduce cardiac workload and help overall the patient with their cardiac output. Because of that, SGLT2s in a bunch of the updated guidelines have now become the fourth official drug class for heart failure. So we said at the very beginning of this lecture, we have beta blockers, we have diuretics, and we have the ACEs or ARBs. This is very quickly becoming the fourth, I shouldn't say quickly, but more commonly becoming the fourth drug class as part of that regimen that patients with heart failure are being put on this. This drug is a diabetes drug, but it has officially become labeled in the last few years as a heart failure drug. The major adverse effect of this is UTI in females, and it does have a positive benefit in most patients that it also can cause weight loss. We discuss this drug further in the diabetes lecture, but this is definitely fair game for the NCLEX or your pharmacology course in regards to heart failure patients. Let's go and talk about a few last points as we wrap up this lecture. Nitroglycerin is another vasodilator. It can be used for acute heart failure, and that's discussed in depth in the angina lecture. However, it's really not used a whole lot for heart failure other than in the hospital setting. Next, I want to talk about a few other things that may show up on pharmacology exams, even though these are not pharmacology. MCAS, mechanical circulatory assist devices, are things like an LVAD, which is a left ventricular assist device, or a balloon pump, which is an intra-aortic balloon pump, or ECMO, which is extracorporeal membrane oxygenation. All of these work to help patients that have some aspect or another of heart failure. I want to be really clear on something. There is no cure for heart failure. The patient has heart failure. We don't have a way to cure it. We manage their symptoms. We control the disease. In rare cases, which hopefully is everyone's goal, when a patient has heart failure, they do a really good job on improving their lifestyle, assuming that it was negative in the first place. But if they do a really good job, if there's a lot of room for improvement and they start diet and exercise and really turn things around, they can get themselves healthy enough to get out of heart failure. But that's not common. What we try to do is to try to manage the symptoms. The only actual treatment for curative treatment that makes that the patient no longer has heart failure, other than doing a complete 180 on their life, if there's room for improvement, which not everyone has. But other than that, is heart transplant. On a test, heart transplant would be considered the definitive treatment for heart failure. All of these medications are just there to manage their disease. I'm not going to go through the last class of drugs, but I did list it here in case your course wants you to cover these here. Most of these are covered in an adrenergic lecture and shock lecture, which is where we put it in bullet point nursing. But I did list it here in case your program is going to discuss vasopressors over here. So I did go ahead and list the entire drug over here. Here are your references. Please like our channel, subscribe to our channel, and if you have any questions, reach out. Have a great day.